you're seeing people that actually have cleaned up their world and are now holding down a job and actually being, because they didn't set out to be this way. They don't want to be this way. They've just got hooked and can't get off. So this has really improved, I think, the community's options on making it better. Like I said before, it's not going to happen overnight. It didn't get this way overnight, but I think this is a huge step forward to improving it and hopefully make it better for our kids down the road.
Hello, you are listening to The Local Lens, the podcast from the Powell County Health Department and Kentucky Rio, where we go inside our community's experience with the drug epidemic. Our show is coming to you from Stanton, Kentucky, a small town nestled at the foothills of Appalachia. Our goal with the show here is to gather and show you as many unique perspectives on the drug addiction problem as we can. And today we are joined by a couple who has a very, very unique perspective on it. It's a married couple who together run the EMS in Estill County, Irvin, Kentucky. And then the husband is also the coroner, and the wife heads up all the data reporting in the area. So this couple really has a good grip on what the addiction world looks like there in Irvin. So several years ago, Estill County was ranked the #1 overdoses per capita county in the country. And we've not gotten very far from that point. So these two are very hands-on dealing with this issue every single day. So we go over as many different parts of their job and their world that they want to. We had the interview in the EMS office, so there's going to be some noises from daily EMS activities. So we do beg your pardon on that, but I thought that was actually pretty cool. But anyway, I'm your host, Nate Brooks. You're listening to The Local Lens. These are our people using our voices, telling our stories, because no one sees it like we do.
Well, I'm Jimmie Wise. I'm the director of Estill County EMS. I'm a graduate of Eastern Kentucky University. My degree is in pre-hospital emergency medicine, and I hold several different types of certifications, instructor and provider certifications alike. I've been here at Estill County EMS since 1990. I really have been fortunate to be able to work and live in our town that we grew up in, and went to school here. So it all kind of is been kind of handy. Not that there's anything wrong with working out of town. I was always, I've had different jobs in different cities doing different things, but full time and part time, I've always been in Estill County. Mm-hmm. So nice.
Well, of course, I'm Sheila Wise, and I am paramedic training major for Estill County EMS. I graduated from the University of Kentucky with a degree in accounting and a minor in computer science.
That's not what you're doing now. But
no,
go Cats.
No, yes, very much so. I am 110% UK. So it is totally the opposite end of the spectrum, because I get very bored when everything's going smooth in accounting. Mm-hmm. And I started playing in EMS, and when I started playing, the more I played, the better I liked it, and the more I liked it, the more I stayed.
So together, these guys are running the EMS and also the coroner's office in their hometown and the town they live in still. So it almost feels like every emergency in this town is on their shoulders.
It's a big advantage or disadvantage, however how you want to slice it, where you work and live in the same town you grew up in. So a lot of the people in a lot of places we go, we know the people, we know the area. Sometimes that's good, sometimes that's not as good, you know. But I mean, you pick up people that you know, family members or friends or something, and that works. You know, works.
Makes it harder sometimes, but then at the same token, it makes it easier on families. A lot of times they know who they're giving their loved one to, and know we're gonna do everything we can to take care of them, and that means a whole lot. We pretty much live, eat, and sleep EMS and rescue and coroner's office and the whole 9 yards. So it's a part of our everyday 24/7 life. Mm-hmm.
So yeah, you know, you got people that see on the street and stuff, and it's, you know, they'll show up at the house asking questions. It's you know, it's got its pluses and I guess negatives too. But I don't think I'd trade it for anything else that we've ever done. I mean, we've both had other hobbies and knickknacks and jobs that we've done, but it's been pretty rewarding.
And we keep saying my ideal job in the future will be a paramedic on an island where I can wear flip-flops and sandals and sunglasses to work every day. Yeah. So that's my goal in my old years of life.
And she deserves it. Working in the EMS is not any kind of a luxurious lifestyle to have.
This is what we do. We love it. If you don't love it, you don't last very long. Mm-hmm. But we also plan to be here for a long time. Unlike people today, usually 5 years is a long time. Mm-hmm. Burnout rate's 5 to 7. So, and we've been in here 20 plus years, you know. So, it's something we set out to do. This is what we wanted to do together, and this is what we wanted to do for our community, because this is where we were born. I was born here. So when we grew up here, both families had businesses here all our life, and this is what we wanted to do. And we've been lucky enough to be able to do that here, and that's been huge.
So even though you hear them talk about how much of a blessing it's been for them to work in this, they've had a really hard time finding other people to work in it with them.
You know, one of the biggest downfalls we've got is we can't pay. We can't pay the monies to EMS that a lot of the great big counties can't. So the further back in EMS you go in eastern Kentucky, the further back you go, even when you go towards Powell, Lee, you start going up in the eastern Kentucky, the money is, you don't, why would you want to get into EMS? I mean, as a paramedic, you know, on average, most of your paramedics have the same, you know, have a 4-year degree. A lot of your nurses have a 4-year degree. Why would you want to get into pre-hospital care when you could get into in-hospital care as a nurse or working in healthcare? Because EMS is one of the lowest paid positions in the healthcare system.
You get burnt out very easy. Our crews get very disgusted with the runs, with the lack of pay, with the lack of sleep. You don't eat well, you don't sleep well. There's nothing healthy about EMS. And that's why I say if you don't love it, you can't stay in it.
So what is there to love about it? You just gave me a very good list of reasons to stay away.
I did. However,
I'm thinking about quitting now.
Yeah, well, and there are, but you know, and I look back at that, and I say this on a regular occasion. There's lots of days I think, you know, this is stupid. Why am I doing this job? Because I make a whole lot more money in accounting. I'm very good at accounting. I get very bored, but it's a lot safer. I don't have to worry about any kind of bad germs. I don't have to worry about getting hurt out on a run. But then you have some little man, some little lady, and they pet you on the hand, or they say thank you for what you're doing, and it's like, stupid, this is why I'm here. So that's why you do it. It's because you truly, truly enjoy what you do.
And you started to hit on something there that I'm curious about over here, because I know that the Syringe Exchange service in Estill County has had what I would say a turbulent history, like whether it's just running or not. In Powell County, one of the things that our police force has praised about it is that they're now more confident going on runs and things, knowing if they get stuck by some renegade needle, then they have a less liklikelihood of getting sick. Is that something you guys worry about?
Oh, heck yeah. We worry, and from our standpoint, I'll say this, and Jimmy can back it up, but we're sending out our kids because they're young. They've not been in EMS that long, a lot of them, and they don't have the experience. And you're sending them on a scene that may be safe or not safe. There may be needles that they get stuck with, or there may be irate individuals when they get there. It's just not a safe environment, and it's probably less now than it ever has been. But yeah, the needle exchange, we're 100% for because of our safety, because I think that makes us feel better, that there's a better chance of us keeping our crews safer. And
I go on a lot of runs with the crews as a supervisor too, because I do a lot of field operations, and if it's a overdose, I go, you know, we've got a chase vehicle, and we're seeing a lot of needles. I mean, we really are. And but you got to look at it from an aspect of, and there's two sides of the coin, it really is. And when they first discussed it, when we were first talking about needle exchange, I wasn't a real big fan of it, to be honest with you. It's something that was just kind of like, okay, didn't sell me on it. So my intent at that point was, okay, let me sell me on this information. Tell me what I need to know that's going to make a difference. And the more I go out, and you got to keep in mind, the more you go out with overdoses, the more overdoses we see, whether needles are on scene or whether they've been removed by whomever. You know, a lot of the families know that their family member who's addicted, you know, they're hepatitis positive. They know that, okay, in-house. And you got a lot of grandmothers, you got a lot of moms, you got a lot of dads that'll be like, hey, I'll do what I got to do to make sure he's going to use, she's going to use. We know that. We understand that. It's going to happen. If you think it's not, you're crazy. So I'm going to do everything I can from the parents' point of view is what they're thinking to make sure they have clean needles. And that happens.
It protects them
It
as well
does,
as us.
because
So it protects the whole family.
so when you look around, you know, are you taking care of every aspect of this of it? Is it a perfect solution? No. But we have had EMS people, we've had fire people, we've had one of local law enforcement, sheriffs, and cities too, that city officers that's been stuck. You know, I would be much more comfortable knowing that we've got a needle exchange program where there's the chances of a cleaner needle being out there, clean needles, than not. Now, are you still going to get them on the street? Yeah, you are. I mean, you get a cop pulls in behind somebody in his paraphernalia, they may very well throw it out the window. You know, you're going to see needles. But the statistics, if you look on the national average, when you're looking at the needle exchange programs, statistically, it works. Because if you start thinking how much it costs to treat a hepatitis patient, you're dealing with hundreds of thousands of dollars per patient over several years. So if you just saved one of those family members from getting hepatitis or sharing a needle with somebody else that's an addict, you've saved hundreds of thousands of dollars by simply securing a clean needle. So, you know, and it's not perfect. There really isn't. You're going to have negativity, and there are negative aspects of it. You know, we look at it one way, family looks at it another way, police department looks at it this way. You know, and there's no perfect solution. But
From our standpoint,
it tips the scale, and if it tips the scale to where one of the guys, one of the cops, or one of the firefighters or EMS or whoever, if it tips the scale to where if they're less likely to get into a dirty needle, less likely. I didn't say that they were going to be no chance of it, but if they're less likely, you know, I'm for it. And it's proven that it has worked. So,
and when you say that it's worked, just to clarify, what does it mean for the program to work? That saving money?
Well, you got to get everybody on board. Start with step number 1. Priority 1 is you have to get everybody on board, and that starts with you need to have a group discussion with all your players. Some of them are not going to want to play. I don't know. Maybe political. It may be judicial. When you get to the end of it and look at the fact that you've got people who don't want to participate. You get past that. Okay, that's not going to work. But when you get everybody together, you get your EMS together, you get your police departments together, your judicial, your judges, magistrates, and say, okay, get them together and educate them. Let them make their own decisions, because that's what had to happen to myself and several others. You know, I had an opinion, but I didn't have an informed enough to have a decision. So when you explain to them and get them to work with you, and a big component is your law enforcement. And the law enforcement want to help, because they realize that just simply throwing an addict in jail, that's not really the solution, honestly. So there's other avenues coming around about that, and they have to get on board with it. They have to say, okay, what happens if you have a needle exchange program? What happens if you've got needles in the vehicle and you know that they've got the proper credentials, that they're going back to the needle? You know, you have to have that aspect of common sense.
That's how you know it's working, is when you do have those individuals that are bringing them in. It makes it safer for us in the long run. It makes it safer for the families in the home, kids. And it also is getting those people help sometimes that want help and don't have a chance or not educated about it enough to be able to get that help. And help is difficult to get sometimes, especially when you don't know where to reach to. So with the exchange program, they also have all those educational processes for them and can set them up with people that can help them if they want to get clean, or if they want to make sure somebody else in their family is safe, or if they know their hepatitis or this, they can get avenues to help them with whatever's needed. And you don't always get that education out there if you don't have somebody to give it to them. And that's one of the spots the needle exchange program is very strong in.
And in the needle exchange, I'll be the first to admit there is some different areas where there's some weak spots in it. So
yeah, let's talk about that. Yeah, let's go into. We do a lot of praising syringe exchange programs and all that. Why are they bad though? Why are they incomplete?
Well, one of the things that a lot of people think is that if you get, I'll give you 10 needles. At the end of the day, I bring back 10 used needles and I get 10 fresh needles per se. In an ideal world, that's what happens. Some people are embarrassed about coming back and exchanging needles. Sometimes they'll take the 10 needles, but they won't bring back the other 10 needles. So, I mean, at the end of the day, you have to be up and honest with everybody. Your city councils, your magistrates, your judge, and say, this is the way we're going to do it, and this is the way we have to do it for this to work, and stick with it. There are a lot of times whenever they don't bring back 10 needles, they throw them on the street. But they want the 10 fresh needles, so you got to work around that. And one of the things I hear a lot of people talking about, well, I'm a diabetic and I don't get free needles, So you have to work avenues around that. And
that's a bad thing too. But there's so many other avenues that it goes into that you can't fix them all.
There's going to be failures in some parts of it. Yeah, there
is not a true fix, but it is a start. And I think that's where one of the things that has to work the most or the hardest is to keep it moving forward and improving it, no matter where it's at today. You got to keep it going forward and improving it, because you don't know those other avenues until you get into it really deep and you're with people that can help you say, well, that this is what's going on the street, and you learn from those experiences you're getting from those individuals when they trust you enough to come back to you. So they've got to have that trust as well.
It sounds like you could also sub in Narcan to this whole conversation as well, and especially Narcan's a Band-Aid. That's what a lot of people will say about it, and it helps, but yeah,
it's not going to solve the problem. And solving the problem, we didn't get this way overnight. It's not going to be fixed overnight. It's going to take some trial and error. Narcan is a Band-Aid, I think, because I also think the education's not there, that people don't understand. Narcan doesn't work on anything except for opioids, and they think it's the cure-all for everything, and it's not. And so it's an education process that has to be improved and continue improving so that we can move forward again.
And there's a lot of designer drugs out there that Narcan doesn't work on. There's a lot of medications that it doesn't work on. Right now, we're seeing a lot of fentanyl. It does work on that, and I mean that's pushing the streets right now. And we've. Everybody knows this. We're in an epidemic. You don't need us telling you that. I mean, you can turn around to ask your neighbor. You can ask your kids at home about their friends and say, hey, who do you know XYZ? There's more drug abuse and use right now than there has ever been. I mean, from a coroner's aspect or from EMS, there's more today than has ever been. And it's not getting any better. I mean, I've got people who are not even calling EMS. I mean, they know how to use Narcan as well as we do. We're giving them plenty of Narcan. They have different avenues to get it. So, I mean, we'll get dispatched out, which is kind of amazing. I never saw it years ago, but we'll get dispatched out to someone not breathing and not have a pulse. And somebody will give them Narcan at the house, or you'll have, our law enforcement also carry it. They'll get it before we can get there, and then they'll sign out, or they'll be gone from the scene before we get there. And they weren't breathing, and they couldn't feel a pulse on them when they called. And it's like, I've never heard of that before. When I first started in EMS in early 91, I was given 0.4 milligrams Narcan per dose, and that's less than half a milligram. Now we're given 12 to 15 milligrams. 4 milligrams.
4 milligrams, the smallest we give now.
Yeah, because the drugs we're seeing now are so potent, they're so crazy. The fentanyl is bathtub fentanyl is so critical that you just got to get it on board and got to get enough of it on board. But the education, like Sheila was saying, is real important because people still don't really understand. I've got somebody that's wide awake, screaming and hollering and jumping around the room like crazy, and the law enforcement will be trying to get them down, and somebody will yell, give him some Narcan, and we're like, well, he doesn't need Narcan. That's not the issue. When he quits breathing is when you need Narcan. So,
but I think the Narcan has developed even from that point where we've had so much Narcan, we're giving Narcan, it's getting out there. But what has transpired from that is our QRT team, our quick response team. If we go out to an individual's house and they tell us it's okay for the QRT team to make contact with them within the next 24 or 48 hours to give them options that they never had before. And we go out, we make this contact, we talk to them. If you want rehab, we can get you in rehab. If you want this, we can help you if you want help. And that never was an option before. Today, with all of the Narcan process and all that has gone on, it has graduated to add this component, which we have learned and know that we need, but we've learned how to mix it in. So if you give Narcan, our crews are asking the individual, would you be okay for somebody to come back and talk to you tomorrow?
Sometimes there are, sometimes they're not. Yeah.
But a lot of people are, and we've seen some good outcomes.
We go back out with EMS, with one of us. We go out with a peer support specialist. Somebody's been there and done that. We go back out if need be with mental health. We have that avenue. Go back out if need be. Law enforcement goes with us. And we reach out to them and we have information. And sometimes that's an avenue they're interested in at that point. And sometimes it's not. I mean, you've got those, and we all can probably point to somebody that, they don't want help. They're in denial. They're not going to get help. There's nothing about it.
Because they've got to want it for it to work.
Step number one, they got to want it.
But if they do, we have ways of reaching them now, and that we didn't have 6 months ago, a year ago.
How essential now that you have the QRT is that to just the whole picture, I guess? Specifically what the EMS is trying to do, but also just the whole trying to get people into recovery.
I think it's huge because the community in general is struggling every day, whether it's the families, whether it's the school system, whether it's the employers, whether it's the religious side of it and the churches and those guys. Everybody's seeing it. This is affecting everybody's household. I don't care who you are. And this is giving some options to these individuals that really want clean and don't know how to get there. And the individuals we have working with us, they take it to heart. They really want to help you. No different than us, just in a different way. And we're actually seeing individuals that are not necessarily coming back home, because I think that's very hard for them to do. I think they can't come back to their same friends, their same world, their same everything, and stay clean. But you have options. And with that, you're seeing people that actually have cleaned up their world and are now holding down a job and actually being, because they didn't set out to be this way. They don't want to be this way. They've just got hooked and can't get off. So this has really improved, I think, the community's options on making it better. Like I said before, it's not going to happen overnight. It didn't get this way overnight. But I think this is a huge step forward to improving it and hopefully make it better for our kids down the road.
Yeah. We're getting very close to the end here, but Sheila and I have a shared love for data, so I had to ask her about that. What's the most surprising trend you've seen?
I think for me, the surprising trend, especially in overdoses, has been the fact that, and of course I keep up with it on a day-to-day basis. I read all the runs. I know if we've had an overdose and over the weekend, over the day, last 24 hours. It surprises me that the average age group is 35 to 45 that are overdosing, not our teenage and 20-year-old kids. We have those too, but the larger numbers are in the 35 to 45, and the larger numbers are female than male. That's extremely surprising in one aspect, but in the other it's not, because it's a proven fact that females can handle pain a lot more than men. So they get hooked easier. When they honestly get hooked, because they get hooked usually because of chronic pain, and it wasn't something they really just set out to take drugs because I want to take drugs. It was doctors giving me pain meds for my back or for whatever, and then now he's kept me off, and I still have that addiction, and I need it.
And maybe that's why the 30 to 40-year-olds are
I
there,
think so.
because we had the OxyContins back in the in the 90s, and that you saw a lot of people who And everybody thinks that your addicts are, they're not real smart, blah blah blah. No, they're bright, they're super smart, they're brilliant. In all honesty, they just got in a bad path. Maybe the doctor cut them off.
Made some bad choices.
Maybe made some bad choices. But I mean, at the end of the day, they're in a bad spot. And on average, a very small percentage of those who want to get clean successfully get clean. The statistics change, and I hesitate to quote them, but the statistics are not very good for that. So at the end of the day, we're seeing, and I want to clarify, an overdose is not a death. An overdose is somebody that we get toned out to, or the police gets toned out to, or somebody we run out who has passed out in a car or something. We kind of kiddingly say too, don't pull on the side of the road and check your email, because we get toned out to those too. I mean, anytime somebody
people assume.
Yeah, I mean we get several of those, and most EMS across the country does. Somebody takes a nap, sitting in the parking lot waiting on the wife to get off at Wendy's or whatever, and Nick, he wakes up and there's 5 people standing around his car thinking he needs Narcan. We do see those, but
But I love the numbers, but I think the numbers speak volumes, especially for each community. And most of your average everyday citizens, and I know you and I spoke before, and I told you I've gone to the Ministerial Association and talked to them. I've gone to Kiwanis. I've gone to health departments and sat down and gone over things with them from our aspect and our point of view, so that, because we are on the front line, we see it, the numbers tell us how bad it gets. So, those things are fascinating to me, how we put all that together, but it also helps us apply for things and reach out to try to make a difference.
And really, the entire goal with everything in this is to make things a little bit better. But anyways, here we are with our final thoughts.
But I always like to point out, whether it's to the Ministerial Association, Kiwanis, to any churches, always be cautious. If you have a friend or family member who's been incarcerated for like 90, 120 days, they've been clean for 90, 120 days, etc., and then they come back home, and then they fall off the wagon, or they have access to what they get, and they go back to starting back at their regular dosage that
what
they
did when they went in.
X milligrams is what they went in. Their body builds a tolerance. So we have seen several deaths in this area, several deaths over the fact that, so-and-so's been in jail for 90 days, 120 days and clean. And I'm not going to get into the aspect of drugs in jail, but they've been clean for 90 days. They come back, and next thing you know, they're dead because they jumped right back on the same dosage that they were at. So I always like to point out to people who are the preachers that are supporting, they're trying to do counseling to the families and all. Just be aware, be cautious, cognitive of the fact that if so-and-so comes back into the house, and if there's a chance they may, just understand that you can't. They've been clean for 90 days. Your body's built up tolerances. So
they need that education to know that, hey, you got to be careful, because if you don't, this is what's going to happen. Because that's not what they want to happen at all, and it's just kind of caught in that vicious circle.
It's vicious.
It is.
Yeah.
It's sad.
Yeah, really.
It is really sad.
That's all the time that we have today, folks. Thank you guys for listening in for the episode. Thank you so much to Jimmie and Sheila for coming on our show and taking your time to do this. Hopefully people are listening and really learning a lot from you two. I definitely know that there is a lot to learn from you two. And here is the official shout out to Ethan Moore from WSKV. Thank you guys for broadcasting the show. And also thank you to the Powell County Health Department and the Kentucky Rio, their CARES project and the Coach project. Both of those are the ones that are funding this show to be happening. So thank you so much to you two. So jumping back to Jimmie and Sheila, y'all are a real wise couple. Thank you guys for doing this again. And please, for the sake of all of us, please keep doing what you're doing. Anyways, you've been listening to The Local Lens. I'm your host, Nate Brooks. These are our people, using our voices, telling our stories, because no one sees it like we do.